welcome to Glenmark Kenya's Health Awareness Podcast, the podcast dedicated to bringing you the information that you need to stay informed in order to take control of your health. Today's topic focuses on men's health and in particular, prostate cancer. I am your host, Dr. Laila Kasumba, and today I am joined by renowned urologist, Dr. Muigai Mararo. He will be taking us through prostate cancer from diagnosis to the treatment methods available and even how living with prostate cancer affects patients. Thank you for joining us and welcome, Dr. Muigai.
Thanks, Doc. Thanks, Dr. Laila. And thank you very much for having me here. Ladies and gentlemen, my name is Muigai Mararo. I'm a urologist. I know most people don't even know who a urologist is. A urologist is a doctor, is a surgeon who deals with the genitourinary system. Basically, that is from the kidneys, coming down to the bladder, to the prostate, to the urethra, to the male reproductive system. And a urologist is not a male version of a gynecologist. A urologist treats both men and women, right? I've been working as a urologist in this country. I work for the county government of Taita Taveta, in a hospital called Moi Hospital in Voi. But I also do private practice in Nairobi. Yes. And I'm very strong on health education, health awareness. Yes.
Okay, so thank you so much for joining us. And clearly, whether you're just tuning in for your own knowledge or whether it's on behalf of a loved one, this is the right place to be. So let's get started. So to begin, what is prostate cancer?
So probably before we go into prostate cancer, we probably need to tell the viewer and the listener what is a prostate. So then they understand where we are coming to when you're talking about the cancer of the prostate. Yeah. So most people don't even understand what the prostate is. So the prostate is like a small gland. It's the size of a plum, it's about 25 grams. Mm-hmm. And it is usually located just below the urinary bladder, right? So most people come and tell me, Doc, I can feel my prostate. No, you cannot feel your prostate. It's inside, just below the bladder. And the work of the prostate pretty much is that it helps to nourish the sperms. Okay, it releases some nutrients that help to nourish the sperms. So that's pretty much the prostate. Several conditions affect the prostate. One of them is that the prostate can get infected, something called prostatitis. It can become enlarged with age and start blocking urine, which is the more common problem that affects prostate, and that is called benign prostate enlargement. And then there is a scary one. It's called prostate cancer. So cancer can affect the prostate. And in fact, prostate cancer is the leading cancer in men in Kenya today. So that is pretty much why we are talking about prostate cancer. And also we want to create awareness because again, September is prostate cancer awareness month. So we need everyone to be on board and understand and know how to take care of their prostate health. Mm-hmm. Yes.
Okay. Thank you very much. So what are the similarities or maybe differences between, you mentioned the prostate gets large with age, at what point is it just it getting large and at what point does it become cancer?
So for a start is that there is usually no relationship between the cancer and enlargement. Okay. So one does not lead to the other. So enlargement does not lead to cancer and cancer does not lead to enlargement. They are independent disease entities on their own, right? The similarity is that they can both occur at the same time. Okay. So you can have your prostate is enlarged and it has cancer at the same time. And in fact, most men we diagnose with prostate cancer, they usually come to the hospital because of urinary symptoms, which are not the symptoms of cancer. They're the symptoms of enlargement.
Because like you said, it blocks the
Yes, it blocks the urinary system. So that's what will bring them to the hospital. Then you actually find out, oh, these guys have cancer, right? So that's the only correlation, but one does not lead to the other. So you can have cancer of the prostate and your prostate is small. You can have cancer of the prostate and your prostate is enlarged, is big, okay? And the size of the prostate really does not equal to even the symptoms, right? But like I've said, you can have both at the same time, but one does not lead to the other.
Okay.
Yes.
Okay. But are there any risk factors, say, that would make one susceptible? Susceptible. Yes, thank you. To getting prostate cancer later on.
So the risk factors, basically you're asking what leads to prostate cancer. Yeah. So what are the risk factors? So what would make someone susceptible to prostate cancer? Of course, number one, and this is, I need to put this clear because most people do, there are people who come, a wife and a husband, and they ask, Daktari, my husband has prostate cancer. Is there a chance that I can get it? So number one, it only affects men. Okay, only men have prostate cancer. It does not affect women. Okay, so the older you get, the higher the risk of you getting cancer. The median age of diagnosis of prostate cancer is about 66 years. Okay, and it is pretty common. 1 in 8 men will get prostate cancer.
That is a high number.
All right, that's a high number. 1 in 36 men will die because of prostate cancer. All right. And the main risk factor for prostate cancer is family history. So if your grandfather, your father, your brother had prostate cancer, then there's a very high chance that you'll also get prostate cancer. So family history is a very, very big risk factor.
So is family history just like, okay, my dad, my brother, or can it also be my uncle, my cousin?
No, mainly on the paternal side, not maternal side.
Okay.
Yes.
Okay.
So we are talking about your paternal grandfather, your father, your brother, that line, not the line of your mom.
Okay.
Yes. Okay. Yes.
All right.
Okay, so that's one. Of course, the other thing is something called genetics. Some people have inside their DNA, there are some genes that have malfunction, and then you end up with prostate cancer. And then there's something called race. Okay, so it is more common in blacks than in Caucasians, right? And we usually find that usually the blacks are more common, more predisposed to getting prostate cancer, and they're more likely to get a more aggressive disease than the Caucasians. Yes.
That's not fair.
I know, it is not fair. Then the other thing I need to mention is that what has been found is that people who smoke and people who are diabetic, those two don't lead to prostate cancer, but you are likely to get a more aggressive disease. If you're diabetic and if you're a smoker, you're likely to get a more aggressive disease than people who do not smoke and people who are non-diabetic.
Okay.
I think the other thing I need to address at this point, Doc, is that I get a lot of questions that does sex or lack of it predispose to prostate cancer? The answer to that is no, it does not. Whether the frequency or absence of it, it has no relationship with the prostate cancer. I think I need to put that clear because that question get asked 1,001 times.
Okay.
Yes.
Okay. But from what you're saying, the risk factors, all of them are pretty inevitable.
Yes.
See, besides smoking.
It's pretty much something you cannot control. But, and I'm sure we'll come to that, you can screen it much earlier.
Okay.
That's the beauty.
Okay.
Or, well, I don't know whether it's a beauty, but yes, you can screen it.
It's a good side.
It's a good side to it.
Yeah.
Yes.
Okay, so now coming to that, what would be some early signs, maybe early warning signs that someone should get checked or that they need to go to hospital, maybe see a urologist?
So now, unfortunately, for prostate cancer, it does not have early warning signs. And that's why in Kenya today, most of men who come with prostate cancer, 75% of them come when the disease is advanced, when it is stage 3 or stage 4, because it does not have early signs. So when you come specifically because of signs of prostate cancer, it will be an advanced disease. And you'll probably come with blood in urine, low back pain, constipation, and lower leg swelling of the legs. All right. And pretty much that tells you it's a disease that has progressed, because it's either you've come with blood in urine because the prostate, the tumor is bleeding. You've come with back pain because the tumor has spread to the back. Okay. you've come with constipation because it is blocking the rectum, okay? And you're coming with lower leg swelling, either because your blood level is low, something called anemia, or you're coming with lower leg swelling because the tumor has grown and it has blocked some nodes at the groin. Okay, so you get something called edema. So those are pretty much the signs that when the disease is advanced, most people will come with. All right,
Okay.
and that is advanced disease. However, like I mentioned when you're starting, most people come with signs of enlarged prostate. Okay, urinary obstruction. So they will come with, they are not able to completely empty their urine. Their flow of urine is weak, so they have something called a weak stream. They're going to the toilet more often than not, something called frequency. And urine is, they're having something called urgency. Like when they get the urge to go to the urine, they are not able to hold. They really have to go. They get that strong sense of urgency.
I have to go now.
I have to go and have to go now. All right. Others will come with urine retention. Okay. Yes.
Okay.
Yeah. So, and those signs are not specific to cancer.
Yeah.
They are actually more specific to enlargement of the prostate than the cancer itself.
Okay.
Yes.
Okay.
And I also forgot to mention, there are guys who come with kidney failure. Okay, because the disease blocked the tubes that carry urine from the kidneys to the bladder, which are called the ureters. So they will come with, another reason why they will come with lower leg swelling is because their kidneys failed, because of the cancer. Okay. Yes.
So this has been a very grim picture. It's been painted. So
Yes.
what is it that, say, a man can do, say, like a young man in his 20s, in his 30s, what can he do to prevent getting to the point of his limbs are swollen, his kidneys are failing?
Well, in your 20s and in your 30s, just sit pretty, okay? just know, arm yourself with knowledge, okay, about prostate cancer. The moment you hit 45, there's a test that you can do. It's called PSA, okay, from the age of 45. So anyone who has hit 45 should do a blood test called PSA. Anyone who has hit 40 and they have a strong family history of prostate cancer, they should start screening at 40. So basically screening means that we are doing a test to see, are you likely to get cancer? Might you have an early disease? You know, like the way for women, they test for cervical cancer, they screen for cervical cancer or breast cancer.
Yes.
You can do the same thing for the prostate. So PSA is usually produced by the prostate. Okay. It is supposed to be used inside the prostate normally. Okay. So for example, assuming I don't have prostate cancer, well, I don't think I have prostate cancer. So if I go and do a blood test to check my PSA, because the blood test, blood will be drawn, you wait for maybe 2 hours and you get the result.
Okay.
PSA is a number, okay, it's a value. So you get 1, 2, 3, 4, like that. And that value means something depending on what are your risk factors, what are your age, what is your age, okay, and what are the other factors that you might be having. So PSA is supposed to be produced by the prostate to be used within the prostate. So when you take a blood test, it's supposed to be very low. But then there are conditions that can make that level in blood to be very high. Okay. And one of them is prostate cancer. But there are other reasons why your PSA can be high. For example, if you have an infection of the prostate, something called prostatitis. If you had urine retention, if you have been catheterized, for example, you have a catheter because you had retention or you are going surgery or something.
Yeah.
So there are many reasons why PSA can be high, but one of them is prostate cancer. Now, if you go and do a PSA and it is elevated, then it behooves us as healthcare practitioners to find out why is your PSA high. And most importantly, we need to make sure that you do not have prostate cancer. Yes.
Okay. Yes. Okay. And definitely that would be a very emotional process. Like going through, do I have prostate cancer? Going through all of that testing and all of that.
Yeah.
So are there ways that you use to support the patients through this process? Are there maybe resources that they can look up?
Well, I think one of the biggest resources that anyone can get armed with is knowledge.
That's true.
Yes. That one, PSA being high is not equal to cancer. That's number one. And number two, that the real reason why you are taking that bold step to go for a PSA is so that if there is a disease, it can be caught early. Because if we catch that disease at stage 1 and stage 2, we can achieve cure, like complete cure. We treat the disease and you forget you had disease. Okay. But if we catch that disease when it is advanced, then we'll only be talking about palliation, like just palliating the symptoms, so that, but you will not be cured of that disease.
And that is the case. That's what's going on currently.
Yes, that is the biggest problem that we find. Yeah. Most people who come with prostate cancer, either stage 3 or stage 4. And most people will probably end up to a urologist because they had a PSA done somewhere and it is over 100 or it is in thousands. It's in hundreds or thousands, very high. When you know the disease is, that's an advanced disease.
Well, could you give us the normal PSA range as well? Because you mentioned hundreds and thousands.
So PSA is very specific. It's very specific to an individual. But normally between 0 to 60 years, PSA should not be above 4. Okay.
So talking about hundreds and thousands, that's a lot.
Yes, it should not be above 4, right? Between 60 and 80, then your PSA should not be above 6, normally, right? But like I've said, you can have a PSA of 10, but you don't have prostate cancer. Okay, you probably have an infection. At the same time, I've seen guys, it's rare, but it happens. I've seen guys with a PSA of 2 or 3 and have prostate cancer. Okay. So that's why I've said it is very individualized.
Yeah.
This prostate cancer screening is very, very individualized. And by the time you are walking and you want that PSA, you need to understand what that means. That you might have cancer and you're 50. Right? You might have cancer, but it is a low-grade cancer, not an aggressive disease at 50 years. But then what will it do to your mental health, right? You might come and I tell you, it's low grade, let's wait, let's watch it, see how, but you'll not be at peace, right? Because you took that step, all right? So it is very, very individualized. You should have a discussion with the healthcare provider, and then you decide, do I really need to do this test? But the advice is, if you're 45 and above, do PSA at least once, then have it interpreted. Because then once it is interpreted and it is individualized, I will tell you, you need to repeat another one. And if so, when? Okay? Because it's not an annual thing like for pap smears or breast cancer. Yeah. It is very individual. I can tell you, repeat your PSA after 2 years, repeat your PSA after 8 years, or repeat yours. We need to repeat yours after 6 weeks.
Okay. Yes. Okay. So now following that step of diagnosis, what does the prognosis, in your experience, what does the prognosis usually look like?
So, you see, we cannot talk about prognosis before we know what is the stage of the disease, right? So once your PSA is high, we will need to make the diagnosis. Because having a PSA high, we don't have a diagnosis yet. So the next step that we need to do after that is, if your PSA is high, then we need to understand, why is your PSA high? So there's some tests that we do. For example, if you come with a PSA of probably 14 or 20 or higher, I will send you for something called an MRI of the prostate. Because the MRI will tell me, why is your PSA high? Is there, might there be an infection? Is it because enlarged, or there's something? So the radiologist will tell me there's something, we are seeing something in that prostate that is suspicious, okay? We still do not have a diagnosis at that point. The only thing MRI has told me is there's something that is suspicious. Then I will make a decision based on that. Because if the MRI tells me there's something suspicious in that prostate, then the next step I'm going to do is that I'm going to do something called a biopsy, okay? A true cut biopsy. Do something called ultrasound guided biopsy of the prostate. Basically, biopsy means we put a needle, we take a needle, we put it in the prostate, and then we get a small piece of that prostate, okay, in millimeters. It's very tiny. Okay, it's called a core. biopsy. So we take that to the laboratory. We take to someone called a pathologist. So the pathologist will look at it under the microscope of that nodule that the radiologist told us there's something suspicious. And the pathologist will tell us exactly what that is. Only that time can we talk about diagnosis. Okay? The other time we are having an assumption. Okay? Yeah. We know it's highly likely that you have cancer or it's not highly likely. But once we do that biopsy, the pathologist will tell us, hey doc, here, this biopsy is showing you have cancer. Okay? And then he will go further and tell us what grade is it. So basically the grade will tell us in terms of aggression. So there is a grading system. So it will tell us how aggressive is this disease. Okay? And once we do that, we know now that for a fact you have cancer. We still cannot talk about prognosis at this point because we don't have something called a stage. Stage basically means this disease is at this point. Where has it spread? Has it gone further? Has it gone to the bone, for example, to the surrounding or to the lungs? So there are other images that we'll do. So sometimes we'll do something called a CT scan of the chest, or we can do something called a PET scan. So basically that's a whole body imaging. It will tell us. It will look at the whole body and tell us this disease has not spread from the prostate. It's just within the prostate. Or this disease has spread to the neighbors. Or this disease has gone to the bone. Or this disease has gone to the neighbors, to the bone, and to the lungs. See? So only at that point then we can discuss prognosis of this disease. Basically is what is the outcome? What is the likely outcome? Yeah. Yes.
Okay. And in your experience, what does that look like?
So I will tell you that in my experience, prostate cancer is not the worst of cancers. Okay. Okay? Number one is because it responds very well to treatment. Okay, that's number one. Number two, those treatments are widely available, readily available, even in this country. That's number two. And number three is because those treatments are usually covered by NHIF, most of them. So most people are able to afford it because the only thing they need is an NHIF card. Okay. And number four is because most people with prostate cancer do not die because of the cancer. Rather, they die with the disease. They don't die off. See, all of us will die, right? I'll probably slide and hit down and then get a head injury or something, but I'll die.
I definitely hope not.
Yes, I mean, at some point, okay? Yeah. At that point, I probably will have prostate cancer, but I will not die because of the prostate cancer. See? So most people with prostate cancer do not die because of the cancer itself. Most people die because of other issues. They are either diabetic, they're hypertensive, they have heart diseases, or they have kidney diseases, but they don't die of
the prostate cancer.
Rather, they die with the disease. So the prognosis is not bad.
Okay.
Yes. Oh, if that's what you wanted to ask, the prognosis of prostate cancer is not bad. Okay. Yes.
Okay.
So that's on a positive note.
And that is a good thing.
It is.
And especially the treatment being widely available. That's huge. Yeah. So what are these treatment options that people have?
So the treatment options are going to depend mainly on, number one, what is the stage of the disease? Number two, what is the functional status? The functional status basically means like you as Dr. Leila, which treatment option can you withstand based on how fit are you? So you might someone might require surgery, for example, and they are 50, but they are very sickly. So then they cannot.
That's not a viable option.
Exactly. But at the same time, you can meet an 80-year-old who is very fit, who can withstand surgery. So that's what we're talking about, functional status. So it will depend on your stage. So treatment will depend on the stage. It will depend on the functional status. It is going to also depend on what other diseases do you have, the comorbidities. Okay. So now if we take by stage, you take stage 1 and stage 2. And the reason why we screen disease is that we're hoping that we'll get to your disease at stage 1 and stage 2. Because at that stage, you can achieve cure. Okay. And there are several options that you can have at that point, at stage 1 and stage 2. Number one, you can have surgery. Okay, basically that means you go remove the whole prostate and its disease.
remove the whole
Yes,
area.
chapter closed. All right. Number 2, you can have radiotherapy. Okay, so basically just go have radiotherapy done, chapter closed. Number 3, you can have something called brachytherapy. Brachytherapy basically means it's like radiotherapy, but instead what you do is that you go and you have some seeds that contain radiation into the prostate. Okay, and they're going to kill the cancer cells. Okay, so that's for stage 1 and stage 2. And the aim of treatment at that point is cure, to achieve cure at that point. So that's stage 1 and stage 2. Okay, now when you go to stage 3, then you can get cure, but the chance of recurrence is high. All right. So here you use different modalities of treatment. Okay, so you cannot use one. You're going to combine different modalities, and one of them, a primary or a key part of treatment of prostate cancer is something called hormonal therapy. Okay, so we call it androgen deprivation therapy or hormonal therapy. Hormonal therapy basically means, you see, prostate cancer feeds on a hormone called testosterone. Testosterone is produced by your testes. Okay, so once we block off testosterone, the prostate, the disease reduces. The growth of the disease is inhibited. It's suppressed pretty much. So it is usually a very key part of treatment of prostate cancer beyond now stage 3. Anyone stage 3 and above will tell you there's an injection they usually get every 3 months in the stomach somewhere.
Yeah.
Okay, typical. So that is standard, part of standard treatment. On top of that, if it is stage 3, then you'll have either radiotherapy or surgery. Alas, depending on how risky it is, additional treatment modality. There is now some drugs like a drug called abiraterone, which has been revolutionary pretty much in treatment of prostate cancer. So you will have those multiple modalities at that stage. So it will be multimodal therapy. So you'll have hormonal treatment, either surgery or radiotherapy, plus abiraterone.
Okay.
So for up to 2 years. So that's stage 3. Now, when you go to stage 4, then now we're talking about palliation. So you can have all those that I've told you. You'll have a hormonal therapy, standard. And now you'll have either radiotherapy, abiraterone, chemotherapy, depending on your disease.
Okay.
Yes.
Okay. So what about the side effects of some of these treatments? Say like the hormonal therapy, even the radiotherapy.
So, I mean, nothing is innocuous, right? So all of these come with pretty much some serious side effect. One of them, like if you use the hormonal therapy, for example, some of the side effect most of these men will come with, they will tell you they have something called hot flashes. Okay, like like when women reach menopause.
Real menopause.
Yes, it's
Finally putting the men in the menopause.
It's called andropause.
Okay.
Yes, so they will like have menopause. They'll tell me, hey, doctor, there's a time I will feel this intense heat, and I will sweat. I will have to wake up, open the windows, get some fresh air, and then it disappears. Most men usually complain about that. Of course, the other thing these men will have, especially because of hormonal therapy, is that they will have erectile dysfunction. Okay, they will have low libido. And then they might gain some weight. All right. They might get other diseases like diabetes and cardiac diseases. So we usually advise them on probably need to exercise a lot.
Okay.
They need to watch their diet. They need to quit smoking if they're smokers. They need to watch on their alcohol intake, all those things, so that you reduce those, especially the cardiac side effects, to do with the heart, the metabolic syndrome, like the diabetes, the weight gain, all those.
So there's no escaping exercise ever?
No. You're not going to escape exercise. I mean, it's healthy for you.
Oh, yeah.
Then, of course, the others like radiotherapy and surgeries, they will come with their own specific side effects. So every treatment has their own. I mean, even if you take a Panadol, a paracetamol today, it will probably give you some abdominal discomfort. So nothing is 100%.
That's true.
part of treatment of prostate cancer is something called multi-specialty. Okay, you will not treat prostate cancer, say, as a urologist alone or an oncologist alone. Okay, you will need other people. You will need the nurses, you will need the counselors and the psychologists. Very, very important, especially to prostate cancer. You will need a palliative care team. You will need nutritionists and dietitians, those ones. Like, you will need people to tell you how to exercise. So it's a lot of these things that you need. So it's multidisciplinary. And in Kenya today, part of management of prostate cancer is that we like discussing prostate cancer as a group, something called multidisciplinary tumor board. So that whichever treatment that you're going to get is standard across. And then you're able to get all this, you are connected to all this, whether it is a social support group, because we've seen people in their 50s getting prostate cancer. Some of them cannot process it. So they will need social support group. They will need psychologists and counselors, nutritionists, physical therapists, all those things. Yes.
Okay. So now when it comes to now the actual life of a person living with prostate cancer and going through the treatment and everything, how would you advise these patients to adjust their lifestyle?
I'll tell you, Doc, most people with prostate cancer, you meet them walking in this town, you won't know that any one of them has prostate cancer. You see, traditionally, people have associated cancer with probably falling of hair bald.
Yeah.
You won't find that with prostate cancer. Okay, so most men are actually going on with their work, kabisa, completely. Okay. And they are taking their drugs. They are getting their 3-monthly injections. All right, but usually what we advise them is there are several things that we advise them. Number one is that, most importantly, is that they need to adhere to treatment. That's number one. Number two is that they need to go for those 3-monthly or 6-monthly checkups, right? Number three is that they will need to exercise more than before, because this treatment have side effects that can be ameliorated by exercise. Number four is diet. They need to watch their diet a lot. And the diet basically means you need to cut on your carbs. You increase your intake of vegetables, proteins, and fruits, and reduce the starch. Okay, they need to stop smoking, right? They need to reduce their alcohol intake, and then they need to watch their mental health, most importantly. So that means joining a social support group. It is very important for these men with prostate cancer.
Okay.
Yes.
And these social support groups, where can they find them? Do they find them through their doctor?
Yeah, ideally you should get them through your doctors, your counselors. They are there.
Okay.
They are social support group for men with prostate cancer. Yes, and they are available. So anyone who need to join one, they usually can be connected to one, whether they can join either physically, virtually. Yes. And some of these, you see, there are many people who usually support prostate cancer patients. They usually connect them to these social support groups and even organize monthly or 3-monthly meetings, which helps. I find them coming in very handy for these guys, because some of them are very devastated. Yeah.
Okay, so it's just a place for them to discuss what's going on with people who understand.
Yes, it's a place for them to talk with people who are going through similar issues, find out how the family is supporting them, all that. Because some are usually devastated, and some even stop or following up on therapy, on treatment. Yeah.
Okay. Well, now that you've brought up their families also, they would be affected.
Yes. You see,
mentally and emotionally.
Cancer drains you. It drains you in all aspects of your life.
Yeah.
It is going to drain you emotionally. Of importance. It drains you emotionally. It is going to drain you financially, because treating cancer is not cheap. For example, if you're going to have radiotherapy, you will need to go for about 35 or 37 sessions every single day. You are going to the hospital for radiotherapy. You'll probably be in the hospital for 2 hours for 37 days.
That is a lot.
That is a lot.
By NHIF,
even if it is covered, yes, that is still a lot. All right. So financially, mentally, it's going to drain you. Family connections, okay? Because now you're there, you are probably weakly, the drugs are taking a toll on you, you even have lost your erection, the moment you lose that, the self-esteem and the confidence of a man dips. So it's a lot of these things that they need the whole family to come in. Mm-hmm. Yes.
Okay. And are there also support systems for the families?
Yes. They can actually join in these social support groups.
Okay.
Yes. Yeah.
Okay. So it's not just limited to the patients themselves?
No, it's not just limited to the patients themselves. They can join in these support groups.
All right.
And there are people who have very strong family support. There are others who you will only find it's the man coming to hospital alone all the time. Yes. Which I usually find it sad.
That would be very sad.
It is usually very sad. It is difficult.
Like
Yes. Because he's coming and just talking to you alone, doesn't have a shoulder to lean on or someone to just share this burden with. So as much as possible, I try and tell them, just come in with your wife, with your daughter. Somehow most men with prostate cancer usually come to hospital with their daughters. I don't know where their sons usually disappear to. I think the sons are usually there looking for money to send the daughter and the father to the hospital. So they're still supporting their own way.
Oh, that's good. Okay. So now pivoting a little bit, what are some of the myths and misconceptions that you've heard about prostate cancer?
So some of the myths that are found about prostate cancer is, one, which is very common, is that prostate cancer comes because you don't have regular sex, and prostate cancer can be prevented by having regular sexual intercourse. That, ladies and gentlemen, is a myth, okay? Is a lie. Doesn't happen. So that's number one.
That is an interesting myth.
Yes. Number two, I find is that cancer only is a disease of the elderly. Again, that is a myth. I think the youngest I've seen with prostate cancer is a 48-year-old. The oldest I've seen with cancer is probably 90-something, 93-year-old. So it affects the whole spectrum.
Yeah.
Okay. Yeah. And like I've said, the median age is 66 years. In Kenya today, 66 years is a very young person.
That is true.
Yeah. It's a very, very young person. So that's another myth. The other thing is that prostate cancer is going to kill your sexual drive. Okay. Again, this depends pretty much on the stage of the disease. If you come early at stage 1 or stage 2, for example, you have surgery, your erection can be spared and you continue enjoying good sex life. Right? So that's another myth and misconception that is usually there. Of course, the other thing I've seen and I've asked this many times is that prostate cancer can be sexually transmitted. It is not, and it is only in men. Okay. That, Doc, I usually find especially when they come in as a couple, they will leave and then the lady will come back. Doc, hebu niambie daktari, niliambiwa ati ni juu labda hatujakuwa tukipatana na mzee. You feel sad for them because
that's so sad. She's taking responsibility for cancer.
She's taking the fall for the cancer, which is not okay. And it is. Then they will ask you, sasa naweza pata hiyo ugonjwa hata mimi? Like, no, you can't.
That's okay. You're fine.
You're fine. So it is very important for people. So, some of these things that usually sound obvious to most people, they are actually not obvious to everyone.
Yeah.
So it is important to let everyone know that it is that's another myth.
Okay. And these are myths, even though while saying them now, they might sound a bit outlandish. These are things that affect people mentally and emotionally once they get this diagnosis.
A lot. Mm-hmm. Yes. I think those are the main things I usually deal a lot with. Mm-hmm. Yes.
Oh, okay. So just providing that support to them.
Just providing that support to them.
Okay.
Yeah.
Okay. All right. So what does long-term care and monitoring look like when it comes to prostate cancer?
So prostate cancer is a lifelong disease. Okay. So once you're diagnosed with prostate cancer, you'll need continuous monitoring. Even if it was stage 1 or stage 2, you will still need to continuously be monitoring your PSA levels. All right. So this PSA is also very important to monitor the disease progression. Okay. Because, for example, if you come at stage 1 or stage 2 and we do surgery, we go radiotherapy, then we expect your PSA should drop completely, right? Because this process is not supposed to be producing PSA.
Yeah.
So it also means that we'll need to be monitoring to know whether this PSA is remaining down or it's coming up. Okay. Because if it starts rising, then it means there's something is happening, right? So initially we'll monitor 3 monthly, then 6 monthly, then probably annually, then depending on what stage the disease was. But if your disease is stage 4, for example, then every 3 months you'll need PSA monitoring. That is number 1. Number 2, if your disease was stage 4, again, we will, because of the side effect of the treatment that you're on, we'll need to check your blood level. We need to check your liver. We need to check your kidney. We need to check your calcium levels, right? All these things will need to be monitored every 6 months, okay, for life. So, and then of course, you will need to be checking on your weight. Are you gaining weight? Because that, again, if you gain weight because of the side effect of treatment, then it means you're at higher risk of getting those metabolic diseases like diabetes, right? So there are a lot of things that need to be monitored, including the side effect of the treatment that you're getting.
Okay.
Yes.
Have you found patients to struggle with that, to struggle with the idea of I have to come every 3 months, every 6 months?
A lot. I think that is one of the biggest challenges that we usually get. You ask any person who is taking care of a cancer patient, in healthcare worker taking care of cancer patient, I think one of the biggest challenge we get is adherence to treatment and follow-up. Because, for example, someone will have surgery and they're like, this PSA is unrecordable, for example. Do I need to go after 3 months or after 6 months? Maybe I'll do after 2 years, right? So those are usually the challenges that we usually get. Follow-up and adherence is a big problem.
Okay, and also speaking of adherence, because you have to take this medicine consistently the rest of your life.
Yes.
Are there like maybe tips and tricks that you've picked up along the way to help people like just stay in that, okay, I have to take it, I have to remember to take it at this particular time?
There are people who usually, number 1, they set alarms, okay? There are others who have those tablet counters, okay, to help them. But I think what I've seen helping a lot is usually the support that you get, either from family or from the support groups. That comes in handy. Because the moment you have a motivated patient, I think that's the key thing. Once you get a motivated patient, then they will go to all lengths to have their treatment. They will tell you, daktari, nimebakisha dawa za wiki mbili, so I need a refill. See, those are guys who are telling you because they keep watch of their treatment.
Yeah.
So they will come before those 2 weeks so that you write another prescription, because it's a process for them to get those treatments so that they will get them on time. The moment you have a motivated patient, it is very easy for both the patient and the doctor. There are others you'll have to tell the secretary, your patient, call them, find out. They'll be like, daktari dawa ziliisha. Like, mbona hujakuja? Niliona tu nichukue break. And that's normal.
Yeah.
That's normal, doc.
Yeah.
Yes.
Well, are there times in treatments during treatment that warrants a break?
It is not standard of care. Yes, you can, but it is not standard of care. Yes.
Okay.
So there's something called intermittent therapy. You might decide to give them a break, but it is not standard. So it's not something that I'm going to sit here and advocate. Okay. Because it's not standard of care.
Okay, so it can be like, say something happened.
Yes. And probably because of the side effect of the drug, probably their pressure started rising, their sugar became uncontrollable, and you're like, let's take a break from this.
Okay. All right.
Or let's get an alternative. Yeah.
Okay.
Or some patients are not able to tolerate some medication. So at some point you'll have to withdraw that therapy, look for alternative.
Okay. And in that time, obviously they will have to take a little bit of a break.
Yes.
Okay. Okay. So finally, because we've come to the end of my questions for you, are there any key takeaways that you would like anyone watching or listening to leave this with?
I think as a urologist, from where I sit, is that I would want to tell people, number 1 is that prostate cancer is there. It is real. Okay, 1 in 8 men. So these men who probably are playing golf, 1 in 8 of them will get prostate cancer. That's a grim picture. But this disease can also be caught early. And I will tell you, and this is a good thing, is that early on, like 5 years ago, we used to find almost everyone is coming where the disease is advanced. Nowadays, I think because of the awareness like this that you are creating here, the role of the media as well, people are becoming more aware, and they're coming early because people are taking that step, okay, and doing a PSA. And then their disease is diagnosed as stage 1. So we are actually finding, well, the numbers are still slow, okay, they're still low, but we are getting a little bit more people at stage 1 and stage 2, which is encouraging. So you guys keep doing what you're doing, okay, it's creating a good awareness. So do PSA, okay? If you're a man, if you reach 45, do a PSA test, okay? And PSA is not positive or negative. It is a figure. It is quantitative. It is a number. Then walk to a doctor who understands what PSA is, okay? Preferably a urologist. Then have that PSA interpreted based on your symptoms, based on your age, based on your risk factors, okay? Because like I've said, it is very, very highly individualized. So have your PSA interpreted. That's number 2. Number 3 is that if you are a prostate cancer survivor, you are fighting prostate cancer, or you're supporting someone with prostate cancer, know that treatment is there, it is available, and there are people who are willing to walk with you along that journey. And there are social support groups that people can join so that you don't have to carry this burden alone. We are all there for each other.
Thank you so much, Dr.
Karibu.
So final words, like where can people find you?
Oh yeah, right. So like I mentioned when you're starting, I'm very high on creating awareness, not just on prostate cancer, but things to do matters urology. Okay? Like I've told you, we are very few in this country. So most people don't even know what a urologist is, who is a urologist, what a urologist does. They don't know the difference between a urologist and a neurologist. So you can find me on social media. On TikTok, urologist001. Okay. I usually do a lot of videos there where I teach people a lot about urology. Okay, urologist001. So there they will get free education, free consultation there.
Okay.
But if you need to pay consultation fee, you can come to the office. My office is in Upper Hill. There's a building called 40 Suite. 40 Suite is a tall building next to Kenyatta National Hospital. 8th floor, room 9. It's called Mirazi. Okay? Mirazi. That is 40 Suite, 8th floor, room 9. So you come there, and you'll have a consultation. Hapo utalipa consultation fee. But if you find me on my social on TikTok at urologist001 or Instagram at Dr. Muigai.Mararo.
Thank you for joining us on this episode of Glenmark Kenya's Health Awareness Podcast. We hope that you have found this particular episode empowering because this month is Prostate Cancer Awareness Month. Thank you so much to our guest, Dr. Muigai, for all the insight that he has provided. If you have found this episode or any of our other episodes informative, please be sure to share and to like. Stay informed, stay healthy, and we'll see you next time.